Thank you for choosing to watch our educational video. Welcome to Jefferson Health, where our mission is to improve lives. During this video, we will talk about the surgical weight loss options available at Jefferson Comprehensive Weight Management. First, let's start with some background on our team of providers. All of our surgeons are specialists trained by national leaders in bariatric surgery. A majority of our surgeons have more than 20 years of experience, and together have performed more than 10,000 bariatric operations to date. This includes sleeve gastrectomy, gastric bypass, duodenal switch, SADS, and revisional operations. We'll talk more about those during this session. All our surgeons are also members of the American Society of Metabolic and Bariatric Surgery, the governing body of bariatric surgery in the U.S. Jefferson Comprehensive Weight Management offers a full staff of highly trained professionals to help you on your journey towards health and weight loss. Our team includes patient navigators, registered dietitians, schedulers, medical assistants, front desk staff, insurance specialists, nurses, and nurse navigators. You and your loved ones can be confident that we have the full complement of professionals to guide you safely through surgery and the recovery process. So let's talk about obesity and losing weight. During this video, we're going to discuss the disease process known as obesity. Unfortunately, excess weight is responsible for more than 1,300 additional deaths each day and nearly 500,000 per year. Obesity is also the leading contributor to preventable death. The loss among Americans is now surpassing tobacco use, high blood pressure, elevated cholesterol, and all cancer deaths combined. In 1991, the National Institutes of Health established criteria to determine who is eligible for surgical treatment for obesity. Using body mass index, or a measure of body fat based on height and weight, the NIH concluded that people with a BMI of 35 to 40 and certain medical conditions, such as type 2 diabetes, hypertension, high cholesterol, or sleep apnea were eligible for surgery. The good news is that some insurances now cover BMI 30+ with certain medical conditions. Those with a BMI of 40 or higher qualify without medical conditions present. Let's talk about the surgical procedures performed by our bariatric surgery team that are available to you. It is every patient's goal to have their operation with as little discomfort and scarring as possible. To achieve that, our surgeons attempt to do every weight loss surgery with a minimally invasive operation. Doing so leads to faster recovery with less pain. Minimally invasive surgery, known as keyhole or laparoscopic surgery, involves making 5 to 7 1-inch incisions. Our surgeon then places ports through these small incisions and inflates the abdominal cavity with carbon dioxide to create a working space. A camera and long instruments are used to perform the operation under video guidance. Robotic surgery uses similar incisions, ports, and cameras, but the instruments that go through those ports are guided by a computer interface between the surgeon's hands and the robotic arms. This approach enhances the surgeon's ability to see, move around, and access difficult-to-reach areas. Robotic arms have more flexibility in their wrists than humans do, but the surgeon is still the one controlling the robotic instruments. This advanced technology gives the surgeon the ability to do much more advanced and complex work while still using keyhole or laparoscopic surgery. In rare cases, usually because of a patient's prior extensive surgical history or scarring, traditional or open surgery with a bigger incision in the abdomen is still required. Your surgeon will discuss this with you after their evaluation. In general, currently available bariatric metabolic operations feature 2 strategies. The first strategy, and one that all of the operations feature, is gastric or stomach restriction, which makes the functioning part of the stomach smaller. In some of the operations, this is done by removing part of the stomach. In others, this is accomplished by dividing the stomach into a functional pouch and bypassing the rest of the stomach. Our stomach has receptors in the wall that tell the brain when the stomach is full. The stomach lining also has receptors that help our brain distinguish between different types of food. For example, many patients report that their body, and particularly their stomach, feels differently after eating, for example, rice, than after eating something like steak. When the stomach is made smaller with weight loss surgery, most of these receptors still work. It just takes a lot less food for them to be activated, so patients feel full after consuming less calories. When it comes to operations that make the stomach smaller, there is more to the story than just restricting the amount someone can eat. It has been discovered that altering the stomach with weight loss surgeries also affects feelings of hunger and satisfaction. Patients will sometimes report that they simply do not feel as hungry after weight loss surgery. One of the best studied hormones is called ghrelin, which has been labeled a hunger hormone. There are much lower levels of this hormone in patients after weight loss operation, so patients report not feeling as hungry. The second strategy used to help patients lose weight and improve metabolic disease is malabsorption. The portion of our body that absorbs the majority of energy is our small intestine, which is just after the stomach. Food that exits the stomach into the small intestine mixes with digestive enzymes from the pancreas and liver, which causes the food to be broken down into molecules that are then absorbed into the bloodstream through the wall of the small intestine. The food must mix with these enzymes for this to happen. In several weight loss operations, the food and these enzymes are temporarily separated and rerouted. The food travels through one limb of intestine, but there are no enzymes to break down that food, so not much absorption happens. The enzymes travel through another limb of intestine where there is no food. The two limbs, the one containing only the food and the one containing only the enzymes, are reconnected further down the small intestine, which allows for digestion and absorption of molecules of energy to occur. Because some of the small intestine has been effectively bypassed, the body has less surface area to absorb those molecules. As with gastric restriction, there is more to the story with malabsorption. The rerouting of food, in addition to creating a situation where less nutrients are absorbed, also produces changes in gut hormones that promote fullness, suppress hunger, and reverse one of the primary mechanisms by which obesity induces type 2 diabetes. The more we alter absorption, the better the effect on metabolic processes, particularly diabetes. Now, let's discuss the specific operations in more detail. Sleeve gastrectomy features only the gastric restriction strategy. The other three operations, gastric bypass, SATY, and duodenal switch, combine gastric restriction and malabsorption. When patients hear the word sleeve, they think of a device being placed around the stomach. Instead, a better model is to imagine your shirt as the stomach. Then imagine someone taking a sewing machine and sewing the front and back of the shirt together vertically, leaving enough fabric for a shirt sleeve. This is a better visual depiction of what's happening with the stomach in sleeve gastrectomy. The surgeon uses a special stapling device that staples the front and back of the stomach together and then divides it. One part of the stomach is removed permanently. This is a restrictive procedure by removing about 85% of the stomach's capacity. This resizes your stomach to roughly the size of a small banana. Weight loss occurs by restricting the volume of food you can eat at one time and decreases the level of ghrelin, known as the hunger hormone. The average weight loss following the surgery is approximately 55 to 60% of excess weight. There is no rerouting of the intestines in this operation. It is purely an operation based on reducing the size of your stomach. Sleeve gastrectomy can be performed as a single operation that works best if you have a BMI of up to 50. If your BMI is 50 or more, this may be part of a larger strategy known as a staged operation, with the potential for a full duodenal switch or SATY in the future to safely reach your weight loss goal. These procedures are discussed later on. The sleeve gastrectomy is a single organ procedure. It only features gastric or stomach restriction, is the shortest of the operations, and results in the least change to your anatomy. Although permanent in the sense that the removed portion of stomach cannot be put back, it is flexible. A sleeve gastrectomy can be converted to any of the other operations we will discuss. There is also the least chance for vitamin and protein malnutrition with the sleeve gastrectomy. Sleeve gastrectomy is not a reliable treatment for gastroesophageal reflux or heartburn. If you suffer from this condition before surgery, you may have worse symptoms after the sleeve gastrectomy. Some patients who never suffered from gastroesophageal reflux or heartburn may get it after sleeve gastrectomy. The next surgical option is the Roux-en-Y gastric bypass, often called simply gastric bypass. There are two components to this procedure. First, a small stomach pouch, approximately 1 ounce or 30 milliliters in volume, is created by dividing the top of the stomach from the rest of the stomach. In this operation, no stomach is being removed. It is just being divided. Next, the first portion of the small intestine is divided, and the bottom end of the divided small intestine is brought up and connected to the newly created small stomach pouch. The procedure is completed by connecting the top portion of the divided small intestine to the small intestine further down, so that the stomach acids and digestive enzymes from the bypassed stomach and first portion of small intestine will eventually mix with the food. Similar to other bariatric procedures, the newly created stomach pouch is considerably smaller and facilitates significantly smaller meals, which translates into consuming less calories. Additionally, because there is less digestion of food by the smaller stomach pouch, and there is a segment of small intestine that would normally absorb calories as well as nutrients that no longer has food going through it, there is to some degree less absorption of calories and nutrients. Most importantly, the rerouting of the food stream produces changes in gut hormones that promote feeling full, suppress hunger, and reverse one of the primary mechanisms by which obesity induces type 2 diabetes. Gastric bypass is most effective if you have a BMI of up to 50 and also have GERD, metabolic syndrome, particularly diabetes. Expected weight loss is around 60%, with GERD resolution up to 80% and diabetes resolution in the 85% range. Gastric bypass has been around the longest. Its effects and potential side effects are well known. Long-term risks of nutritional deficiencies are relatively low as long as you take your vitamins and supplements. It also treats gastroesophageal reflux, heartburn, and gastroparesis, or poor emptying of the stomach, very well. Many patients who have reflux before gastric bypass report it is much improved or cured after surgery. You are more susceptible to the development of ulcers after gastric bypass compared to the other procedures. Risk factors for ulcer development include smoking, alcohol, and use of steroids or non-steroidal anti-inflammatory drugs, also known as NSAIDs. You are also at risk for a condition known as dumping syndrome, which is a complex hormonal reaction which can cause you to have an unpleasant set of symptoms, such as nausea, lightheadedness, diarrhea, facial sweating, shakiness, and fatigue. Dumping syndrome typically occurs if you have had gastric bypass and eat something high in sugar. For example, ice cream, sweet desserts, and sugary drinks. The syndrome can start 20-30 minutes after eating a high-sugar or high-fat food. It is thought to occur because the normal mixing process that occurs in our stomachs is bypassed in gastric bypass patients. It is not harmful, but patients describe it as unpleasant. The vast majority of patients who suffer this side effect can keep it from happening again by avoiding trigger foods. Finally, gastric bypass can cause internal hernia, where the bowel becomes twisted and blocked secondary to the new anatomic connections inside. This may bring on severe pain in the middle of the abdomen and can become a surgical emergency. Fortunately, this occurs in only about 1% of patients over their lifetime. The next procedure is the SADY. SADY stands for Single Anastomosis Duodenal Ileal Bypass. It is also referred to as Single Anastomosis Duodenal Switch, or SADS, and Stomach Intestinal Pylorus Sparing Surgery, or SIPS. Like gastric bypass, it is also a restrictive and malabsorptive procedure in which the surgeon creates a smaller stomach that is shaped like a small banana. This part of the operation is essentially a sleeve gastrectomy. The surgeon will then bypass approximately 2/3 of the small intestine, resulting in fewer calories absorbed. This also affects the hunger hormone ghrelin, which leaves you feeling less hungry. This procedure is done with a single connection, the anastomosis. Because of the malabsorption, you will need to take lifelong supplementation in addition to the very specific supplementation having to do with the part of the bowel that is bypassed. SADY procedures are particularly advantageous for you if you have a lower BMI and a strong metabolic component, such as diabetes. Reports show that type 2 diabetes can be resolved in the short term in up to 90% of cases. There tends to be more weight loss after SADY than after gastric bypass, and only slightly less than duodenal switch, which we will discuss next. Because the mixing function in the stomach is preserved with this procedure, you are much less likely to get dumping syndrome. You may also have less risk for ulcers compared to gastric bypass. This operation may also help you with reflux and gastroparesis, or poor emptying of the stomach. Finally, side effects such as nutritional deficiencies and loose stools likely occur a little less in SADE compared to duodenal switch. SADE has not been widely adopted for as long as sleeve gastrectomy, gastric bypass, and duodenal switch. Even though SADE is endorsed by esteemed bariatric professional associations as a metabolic bariatric surgical procedure, some insurance companies are still slow to recognize this operation, so access is still limited. The field of weight loss surgery simply does not have as much collective experience and research on this operation. Like gastric bypass, there appears to be a small risk for internal hernia or bile reflux, but this risk also appears to be low, in the single digits. The last procedure we will discuss is the duodenal switch, also known as the BPD-DS, biliopancreatic diversion with duodenal switch. This is also a restrictive and malabsorptive procedure and is very similar to the SADE, where the surgeon creates a smaller stomach shaped like a small banana. It is also similar to the vertical sleeve. The surgeon will then bypass 2/3 of the small intestine, resulting in the body absorbing fewer calories. This also affects the hunger hormone, ghrelin. In this procedure, we create two connections. Due to the increased malabsorption of calories, you will also need to take lifelong vitamin supplementation and occasionally additional supplementation based on your lab levels. BPD-DS works the best if you have a high BMI, typically more than 50, and have a strong metabolic component, especially diabetes. Weight loss is reported at around 80% of excess weight. Type 2 diabetes resolution of up to 98%, and chance of weight recurrence at about 4%. Duodenal switch has been around for decades and is well studied. It has the most weight loss of the operations offered. It tends to treat conditions like reflux, especially bile reflux, and also gastroparesis, the poor emptying of the stomach. It also has the biggest impact on metabolic diseases such as type 2 diabetes mellitus and hypertension. In high-risk patients, this operation can also be done in stages for safety reasons, starting with the sleeve and then completing the full duodenal switch later, even after a few years. Duodenal switch may have the most risk for vitamin and protein deficiencies, particularly if you are not taking your prescribed vitamins and following the prescribed diet. Malnutrition is more prevalent than with any other bariatric procedure, but still only occurs in a single-digit percentage. You may also be at some increased risk for more frequent or loose stools and gas, although these conditions are generally treatable with dietary modifications and medications. Like gastric bypass, there appears to be a small risk for internal hernia, but this risk also appears to be low, in the single digits. There are definitely benefits and risks to bariatric surgery. Your surgeon and advanced practice provider team will discuss these at your consultation. Some of the benefits include long-term weight loss, improvement or resolution of chronic health conditions such as diabetes, high blood pressure, sleep apnea, and high cholesterol. The surgery will also help teach portion control, and research shows that it improves quality of life. Risks of surgery include vitamin deficiency and malnutrition, blood clots, reflux, dehydration, nausea and vomiting, and infection. As we move from the sleeve to the bypass, the SADE to the duodenal switch, we increase the complexity and duration and some short and long-term risks of the operation, but we also increase the potential benefits in terms of weight loss and treatment of weight-related health conditions. Your surgeon will help you decide which treatment is best for you. Researchers compare these operations in terms of effective weight loss by comparing the average percentage of excess body weight lost. It is usually enough weight to help improve any weight-related health conditions, as well as overall well-being. It is also true that you have a better chance of losing more weight than the average based on how well you follow the recommended diet, how much you exercise, and how closely you follow up. Average percentage excess body weight loss for the various operations are roughly 55 to 65% for sleeve gastrectomy, 60 to 65% for gastric bypass, 70 to 75% for SADE, and 80% for duodenal switch. It is important for you to notice that as you go down this list, you increase the potential for weight loss, but you also increase the duration, complexity, and potential risks of the operations. Now we have come to the topic of revision weight loss surgery. The definition of bariatric revision surgery is quite broad. It can range from fixing a minor issue from the initial bariatric surgery to changing to a more complex bariatric procedure, such as converting a bypass to a duodenal switch. So, patients often ask, why would I need a revision? The reasons range from weight recurrence, inadequate weight loss, or excessive weight loss, to unintended symptoms from the original bariatric surgery, such as dumping syndrome, glucose problems, nausea, vomiting, and reflux. First, let's talk about weight recurrence, or failure to lose enough weight to meet health goals. Research shows that the most common reason for weight recurrence is related to patients who are challenged with staying on the prescribed diet, struggling to get regular exercise, and missing regular follow-up with the weight loss surgery service. Although weight recurrence can happen after any of the operations, it is more common in patients with a high BMI who undergo sleeve gastrectomy. The good news is that sleeve gastrectomy can be safely revised to any of the other 3 operations described, and such revisions have been shown to help get patients to their weight and health goals. Weight recurrence in gastric bypass patients can be more complicated, but in some cases, a standard gastric bypass can be converted to more aggressive bariatric procedures, such as a duodenal switch. It has been demonstrated that all patients experience some enlargement of the stomach over time. The sleeve or gastric pouch can become slightly larger and more compliant, meaning that you may eat more food than you could at first before feeling full. There is a limit to how much of the stomach will enlarge, and patients rarely get to the point that they can eat as much at one sitting as they could before their weight loss surgery. Another reason you may seek revision of your weight loss surgery is gastroesophageal reflux. Reflux is when the contents, including the acid in the stomach, travels back to the esophagus, causing heartburn and regurgitation. Many times, these symptoms can be managed with medications, but sometimes the medications do not treat the symptoms enough. If medications do not manage the symptoms, revision to an operation that helps manage the reflux may be required. This scenario occurs most commonly after sleeve gastrectomy, but less than 5% of patients will need revision surgery for it. You may also develop ulcers, which are thought to be related to acid damage. Ulcers occur most commonly after gastric bypass. Smoking, use of alcohol, and use of certain medications such as steroids or non-steroidal anti-inflammatory medications like aspirin or ibuprofen increase the risk of ulcer formation. Ulcers can be treated by stopping the risky behavior, for example, smoking or drinking alcohol, and use of antacid medications. However, if this is not effective, revision surgery is sometimes necessary to remove the ulcer or revise the procedure. The experience of surgeons is essential to the success of your revision. Decision-making is just as important as the technical skill needed to perform complex revisions. At Jefferson Health, we use the newest technological advances to perform the most complex operations with great precision. Robotic systems have made a tremendous impact on revision surgery. The risks of revisional surgery are significantly higher than those of primary operations. It is essential to get a good evaluation, prepare for surgery, and select the right operation. Jefferson's experience and multidisciplinary approach help reduce those risks. A question we are often asked by new patients is, will this work? I don't want to go through all of this and not lose the weight. I have failed every other weight loss method I have tried. Why will this be any different? Put simply, why do these operations fail? These operations are tools. You must learn to use them the right way to have a successful outcome. The best outcomes occur when you take the time to learn how to use this tool in the correct way. It is usually enough weight to help improve any weight-related health conditions, as well as overall well-being. It is also true that you have a better chance of losing more weight than the average based on how well you follow the recommended diet, how much you exercise, and how closely you follow up. The truth of this journey is that no matter how smart the surgery is and how strict you are to complying with the guidelines, the follow-up with your dietitian and surgeon cannot be understated. Your tool will function differently 5 years and 10 years later. Your tool will need to be used differently if you get pregnant or experience new medical conditions that impact your metabolism. Life happens. We cannot stop it from happening. As we get older, we can't stop the aging process. Having a program that can service your tool for the rest of your life is critical to losing the weight and keeping it off forever. There will be an insurance verification form, and on that form, you will have an opportunity to call your insurance company to verify 3 things. First, that surgery is covered under your policy. Second, that our hospital is a covered location. And third, that nutritional counseling is covered as well. The criteria to meet and qualify for bariatric surgery is based on your body mass index, or BMI, and any weight-related medical conditions you may have. First, you must contact your insurance company to make sure you have benefits for bariatric surgery. Every plan and policy is different. Your BMI is the first step in determining whether you qualify for surgery, and depends on both your weight and your height. You can figure out your BMI by using a BMI chart or by typing in BMI calculator on any website search engine. If you have a BMI between 35 to 39.9 and an approved comorbidity or other weight-related medical condition, you may qualify for surgery through your insurance plan. If you have a BMI of 40 or above, you automatically qualify for surgery without having the presence of another weight-related medical condition. A BMI of 30 or above with type 2 diabetes is now covered by some insurance plans. After you have qualified for surgery, you will receive a personalized checklist of what you will need to complete to be approved for bariatric surgery. Each checklist depends on the patient and may include blood work and radiology testing, a letter of medical necessity form to be filled out by your family physician, a behavioral health evaluation, 3 to 6 months of nutritional counseling dictated by your insurance company, cardiology, an EKG, stress test, or an echocardiogram may be required, pulmonary, a sleep study may be required, upper gastrointestinal series, X-ray or gastroenterology evaluation, endoscopy, EGD, right upper quadrant RUQ ultrasound to rule out gallstones. After meeting with you, your surgeon may send you for additional consultations depending on your unique medical history. It is very important to remember you cannot gain any weight from the beginning to the end of your insurance qualification process. Your insurance company can deny you for weight gain. Your chart will be reviewed for the completion of your insurance requirements and submitted for approval. After approval, you will receive a surgery date. Prior to your surgery, you will meet with either your surgeon or your nurse practitioner to review your chart and make sure you are ready for surgery. Scheduling your surgery is actually dictated more by the insurance company than by Jefferson Health. We have no waiting list, so as soon as you get your insurance pre-certification, we will get you scheduled as soon as possible. Congratulations! You have made it to the end of this educational video. We hope you have found the information helpful in answering your questions. So, what are your next steps? First, breathe. You've made the first decision towards a much healthier you. Second, use us as a resource. Communication with our office can be done in a variety of ways, including phone, the My Jefferson Health patient portal, and email. Please let us know if you are getting frustrated, lost, or having difficulties. We can only help if you let us know that you are struggling. At this point, a lot of information has been shared, and you may feel overwhelmed. We are here to help. Just remember, you have taken the first major step by watching this video. Remember why you are here, for your health, for yourself, for your life. We look forward to the next step, which is to make your initial office visit with our bariatric team. This can be done in person or via telemedicine depending on your location preference. On behalf of the healthcare professionals that make up the bariatric team at Jefferson Health, thank you once again for your time and patience today. We hope you have learned something, and we look forward to helping you become a healthier you. If you are interested in learning more about whether bariatric surgery is right for you, please call 1-800-JEFF-NOW or visit jeffersonhealth.org/weight management. We look forward to hearing from you soon.